Okay,
Yes,
now?
now I can. Yes.
So
Yes.
this is a frontal chest X-ray for 55 years old male patient. Try to repeat the history to tell the examiner that you listen to him. And second point, to take few minutes to think about what should be the differential diagnosis. There are cardiomegaly, there are bilateral asymmetrical, mainly on the right, pre-hilar opacification. Um, However, there are no pleural effusion.
Mm.
There are no pleural effusion. There are also bilateral enlargement of the superior pulmonary vasculature, which called the civilization sign. All these signs are almost consistent with cardiogenic pulmonary edema. I will ask the patient for any history of chronic cardiac disease. I will compare with the previous. I will transfer the patient to a cardiologist for echocardiography. 1.5 minutes. Okay. I know
Mm.
that when we are in examination, the stress and the adrenaline is the leader.
Yes.
But don't worry. This is a case you did very well. I give you 7.5. Okay.
Thank you.
Because I ask you, this is a case of acute chest pain. There are
Yes.
continuous diaphragm sign, and there are multiple bilateral in the neck, bilateral streaks or curvilinear and linear radiolucency. And there are subcutaneous emphysema. You didn't mention it.
No, sir, I
Subcutaneous.
mentioned. I did
You
mention.
mentioned?
Yes,
Okay.
sir.
So I'm dealing with a case of pneumomediastinum. My differential diagnosis include one, two, three. You did very well, and you start everything except the most common. The most common cause of pneumomediastinum is spontaneous pneumomediastinum, which need
Mm.
no any treatment. This is that is why I ask you. And this patient
Okay.
was spontaneous pneumomediastinum.
Okay.
Case number two, you did very well.
Mm.
There are multiple bilateral thin wall, well-defined, scattered cystic lesion without zonal predilection in female patient. Okay. My differential, there are no any interstitial lung disease or volume loss. There are no any pneumomediastinum. However, also there are no any pleural effusion. My differential diagnosis would be number one is lymphangiomatosis. Number two, you should do whatever you want, but most of the examiner concentrate on the first differential diagnosis. Tell her I will give you 7.5 at least. But when I show you, this is a CT scan. CT scan. You should ask the examiner, could you show me the mediastinal window? You should. You should. To make
Okay.
him give you the highest mark. Then you can tell him, please, I want you to examine the kidneys. Frankly, when you see, there are few bilateral, small, hypodense, non-enhancing renal lesions, it most probably representing angiomyolipoma. However, I wanted the non-contrast to measure the density. If it is minus measurement, it is fat, and I will confirm my diagnosis. Very excellent.
Okay.
Then you should, if you want to tell me, I will do family screening, I will do brain MRI, all of this, I will be very happy. Okay.
Okay, sir.
Case number one, you did very well, but you delay to tell me about this. About this. This is the first to be mentioned.
Yes,
Okay.
sir.
You mentioned all the finding very
Mm.
well, and you
Mm.
have very high suspicion of diaphragmatic rupture. This is very good. And the
Mm.
fracture. Okay.
Mm.
You ask for CT. When I ask you, when I show you this, and I insist this is a polytrauma patient, the only thing you delay to tell me, oh, this may be pulmonary embolism due to fat embolism. But overall, Dr. Akila, you did very well. In most of
So
cases, I give.
what should I say in when you have shown me chest? What should I say next? What you are
For what?
asking, that what should be the first thing you want to do after after seeing this chest X-ray?
You did very well. You told me you're talking about the hemodynamic stability, and then you talk
Yes.
about the post contractility. You did very well.
Okay.
Just when I show you this, I wanted to alert you about something in the pulmonary artery. Also, not
Okay.
on the pulmonary artery. This is also the fat embolism involving the pulmonary and the brain, both of them. Okay, and especially in polytrauma patient. See, my colleagues, the examiners didn't want more information. They know that all of you are very excellent, but they want procedure. They wanted to see if you are safe or not. Overall, you did very well, Dr. Akila. You are very confident. You pick up the diagnosis very rapidly, except the last case you confused, I think, because it is very easy. But don't
Yes.
worry, all of us did the same issue. Even me, I did it twice. Don't worry. Dr. Amiga, who is third,
Thank you very much, sir.
welcome, welcome.
Thank you, sir.
Yeah, I'm the
Dr.
third one to go. I myself am the third one to go, Dr. Rami.
Welcome our senior Dr. Amiga. Welcome.
Thank you. Thank you.
Dr. Amiga did a lot of effort really. Okay. 40 years old
So,
male patient presented with difficulty breathing.
okay, I'm provided with a non-contrast CT chest, yeah, lung window images of 44 years old male patient who has presented with difficulty in breathing. In this, I noticed that there are multiple opacities noted in the perihilar distribution in bilateral lung, in diffusely noted in the upper, mid, and lower lung zones. Also, I noticed that there are multiple cystic lucencies distributed within
Yes.
these opacities. In my routine practice, I would like to quickly go through the images from cranial to craniocaudally. Um, and also, okay, I also noticed that there is multiple cystic lucency with downwards opacities in perihilar distribution. This make me suspicious of the patient is immunocompromised. This could represent pneumocystis
Excellent.
cerevisiae pneumonia. In my routine practice, I would like to see the. I would like to look for the uh, mediastinal window images also, and I do not see any pneumothorax. Uh, and I would convey my finding to the referring physician and would like to correlate with this with the CD4 counts of the patient, and
Excellent.
uh, and would refer this patient to pulmonologist for further workup.
What are the causes of immunocompromise in patients?
Immunocompromised can be AIDS suffering from HIV, and they can be on long-term immunosuppressants like transplant recipient patients,
If I
and
told you,
that
if I told you this patient is not immunocompromised, this is a hospitalized patient after post-hit trauma. Would you tell me the cause?
in a post-hip trauma patient.
What's your differential diagnosis? This question to
It
give you 8 by 8, by the way.
this can be non-cardiogenic pulmonary edema in that case.
Excellent. Excellent.
Yes,
What else?
or and non-cardiogenic pulmonary edema could also
But
be in the
if I give you history, this situation or this appearance developed 2 to 3 weeks after admission. What's your differential diagnosis?
then this can be neurogenic pulmonary edema.
What else? Neurogenic pulmonary edema is just after trauma, 1 or 2 days. This is 2 to 3 weeks. Mhm.
2 to 3 weeks. It could be mm, in that case aspiration. No,
Don't worry, don't worry. This question just to give you. the full mark, but don't worry.
Okay.
It is 11.
It is not visible. Now it is loading. Yes.
Loading, yes. 45 years old male patient, coughing and difficulty in breathing.
Okay. I'm provided it. I think this is a female patient. I'm provided a frontal chest radiograph of 45 years old female patient who presents
Yes,
with coughing and difficulty in breathing.
yes.
In this patient, I'm not able to see anything on the first inspection, so I would like to go through the image systematically.
Excellent.
Mm, uh, I noticed that there is some area. I noticed that there is some opacity noted in the right lower lung zone.
Okay.
Uh, Apart from this, I do not see any area of consolidation or any opacity in bilateral lung. I'm
Mm-hmm.
suspicious of this opacity. Um, Also, I suspect that there's mild trachea shift towards the right side, and
What
probably
will you
there
do
is some
next?
volume.
What will
So,
you do next?
s- so I would like to correlate this with the lateral chest radiographs, if available, and the previous radiographs, if available, for this patient.
No lateral.
Uh, and compare this with the previous radiographs if available for the patient. Otherwise, if this is the first presentation, I would proceed with the bronchoscopy. I would advise bronchoscopy to rule out any cause of bronchial obstruction the patient is
The
having.
patient in your department. What will you do in your
I would
department?
I would proceed with the contrast and CT chest of this patient.
Okay.
Okay, okay, I'm provided with axial images of the chest, axial contrast and CT chest, lung window images. In this patient, this confirms the presence of consolidation in the lower lung. I would
Okay.
like to I would like to go through the entire stack of images before commenting further. From penile to caudal end. Okay, so looking at the images, I noticed that there is a mass lesion noted in the in the right halar region, uh, which is uh, uh, causing probably this is causing I still want to see the right parahalar region. I'm not able to see.
What will you do next?
Uh, I want to see the. Okay, so probably this has caused obstruction of the right lower lobe bronchus, and
Okay.
this is having this is also encasing the pulmonary artery, right lower lobe pulmonary artery, and there is narrowing of the yes. This right main bronchus is also narrowed, I suspect. In so in my routine practice, I would also look for the um, I would look for the bone window
Hmm.
images to look for any metastatic lesion in the bones, and I would like to see the.
Okay. What will you do next?
Okay, I would advise staging CT chest, abdomen, pelvis. Also, I
And
would advise PET CT of this patient for the staging
excellent.
purpose, and
Excellent.
would refer this patient to lung cancer MDT for further
Excellent.
management.
Excellent, Doctora.
Okay.
What about the time? Still we have time?
Yes,
Akira,
sir,
Dr.
it is
Akira,
8 minutes 14 seconds.
Hmm?
Sir, it,
8.
8 minutes, 8 minutes past.
Okay.
Okay, I'm provided with contrast-enhanced axial CT images, lung window images of this patient.
Yes.
Looking at the images, I'm not able to see any nodular opacities or any area of consolidation in these images. In my routine practice, I would like to quickly go through the entire stack of images craniocaudally. Okay, I'm looking at the bases. Okay, now I can see there are multiple. I noticed that emphysematous changes are noted in the bilateral lungs, centrilobular as well as paraseptal emphysematous changes are noted, and
Yes.
I do not see any pneumothorax. Um,
Mm-hmm.
so I'm not able to see any other area of consolidation or any mass lesion in this patient. Uh,
If I told you this is a male patient who is suspected with a rib fractures,
if this is a male patient who is suspected with rib fractures,
what will
okay,
what is your differential diagnosis?
the patient is suspicious of rib fractures. Um,
The bone is
okay,
okay. Bone are okay. What's your differential?
okay, so I would look for any neoplasm. Mostly it could be pathological fractures. I would look for any source of.
The bones are okay. What's concentrate in the lung parenchyma? What's your differential diagnosis?
Sorry, I didn't. Uh, what was the history you said? Can you please tell me the history of the patient again?
History is irrelevant. This is middle-aged patient, male patient, and you find all of this parenchymal lung changes. What's your differential diagnosis?
Okay, can it these? Okay, I suspect that some of these decencies are lined by the these are lined by the ball. I suspect that these are lung cysts actually. So in my routine practice, I would like to see the
Yes,
coronal also, and I
yes,
suspect that
yes.
these are
Which
hence
zonal prediction are noted?
LCH. Yes, so I suspect that this patient has Langerhans cell histiocytosis, and
What's your
this has
differential?
upper and mid zone predominance, and this spares the lower lung. It spares the bases of the it spares the lung bases. So I'm suspicious of Langerhans cells histiocytosis, and
What's
their
your differential?
differential for this would include, if this is a female patient, it could also represent lymphangiomyomatosis, but this is common in the female patient. A second differential could be
What history you wanted to ask the patient
neurofibromas.
about? What
I would
history?
ask if the patient is if the patient is smoker, then this would confirm my finding.
Excellent. 6-year-old patient complaining of dyspnea.
Okay, I'm provided with contrast enhanced. No, this is I think non-contrast enhanced CT chest,
Okay.
lung images, who is presenting with dyspnea. I noticed that there is a mass lesion noted at the left hilar region with spiculated margin. Uh, in my routine practice, I would like to go through the entire stack of images. Um, so okay, so this is a left hilar mass lesion. I do not see any other opacity in the. Okay, there's. I suspect that there's some nodular opacity noted in the left lung, suggestive of metastasis. Also, there is
Okay.
mild left-sided fluid diffusion.
Concentrate
Um,
on the mass, please.
so, okay, this is. Um, I do not see. I
What's your
in,
differential diagnosis?
So this is a left hilar mass lesion, most likely bronchogenic carcinoma, uh, with metastasis noted in the its lateral lung.
What
I do
type of
not see any.
metastasis here? What type could you detect here of metastasis or suspect, especially apical?
Okay, so I suspect that this is a pancreas tumor.
Not pancreas. This is hilar. You said this is
Okay,
hilar.
sorry. Okay,
Hmm.
yes. Mm. So, okay, I think this is, I think there is some thickening of the interlobular septa also,
Okay,
which
excellent.
is giving rise to lymphangitis carcinoma, and this is a lymphangitis carcinomatosa pattern.
Excellent,
So this
doctora.
is left lung, left hilar mass with lymphangitis
Excellent.
carcinomatosa. In my routine practice, I would like to see the bone window images also to look for any bone metastasis, and I
Excellent.
would
Excellent.
like,
Excellent. Can I wrap up?
yeah, yeah, please.
You did very well, my colleague. This is one example of how you can start very well, then you dropped in between, then you get your balance again. Overall, you did very well, but what I wanted to tell, I gave her 7.5 in the first case, but then she get mentally blocked, and then finally, by help, she answered. This is usually to occur in the Viva. The only solution is to practice more and more, especially under pressure, especially under those who passed Viva, because they have the experience, any of our colleagues. Let's wrap up the case. This is a case of COPD, multiple hyperinflated chest, as you like, multiple emphysematous poly. I could see here there are a large speculating. I'm waiting to listen from you. Speculating mass, speculating hilar mass, okay, associated with extending to the hilum and most probably attenuating or infiltrating the right upper, the left upper main bronchus, result on some sort of volume loss. However, there are multiple scattered nodular curve, bumpy lumpy shape, second septi, which almost representing lymphangitis carcinomatosa. By the way, the lymphangitis carcinomatosa pathology is blood-borne metastasis, not a lymphatic. This is a pleural-based or mediastinal blood metastasis which invade in retrograde manner the lymphatics. Then you detect multiple small scattered or few small scattered left lower lobar and lingual nodules. It may be ipsilateral metastasis. Then you will see, you will examine the rest of the examination. You will tell the management everything. But first of all, I should destroy the case, finish the case from here. This is a mass with a lymphangitis carcinomatosa. This is a hilar mass. That is why I bring up this case. Okay. Uh, the case before, this is also axial CT scan. Okay. Did I show you this case or not?
No, I didn't see this case.
Yeah, okay, خلاص.
I think
You see this
I think
one?
the, is it I think is it pneumocystis I think yes I saw that. I think that was pneumocystis zerovicae. This was pneumocystis
Yes. Yeah,
zerovicae.
yeah, yeah, yeah,
Yes,
yeah, yeah,
yes,
yeah, yeah, yeah.
yes. I
Yeah,
saw this. Yes, I saw.
you did very well. You did very well in this case. Okay, you answer everything. I give you 7.5. See my candidate, my colleagues. See, this is a classic case of PCP or pneumocystis carinii pneumonia, bilaterally higher ground glass appearance intermingled with cystic changes. Okay, I will ask for patient if he is immunocompromised. I will ask for AIDS, for chemotherapy, for other causes immunocompromised. I will transfer to AIDS or immunology and pulmonology MDT for prophylactic treatment. I ask one question. If this, I told you this is not immunocompromised, this is a neurogenic patient or head trauma. You excellently told me, oh, this is maybe neurogenic pulmonary edema. I told you, okay, but this is developed 2 weeks later. This is after due to corticosteroid therapy, which cause immunosuppression, leads to PCP. Okay. All this discussion, when the examiner discuss you like this, trust he wanted to give you more marks because you answer well. This case, I have many notes, Dr. Mega. I have many notes, okay? First of all, the X-ray was very tricky. Really, there are just يعني mild consolidation. Okay, but you didn't mention there are a little bit volume loss here, shifting slightly of the heart and slightly elevation of the diaphragm.
I said there is a trickle shift I mentioned.
You mentioned? Sorry, I didn't
Yeah.
hear you. Yeah, we answer this one. I think this one. This one. Why? This is an example of a very easy case. My candidate, I remark that most of you blocked in easy cases. No, expect the exam will contain very clear and the classic case. I think in my exams, I get not less than 30 or 50% of them of very classic cases. And by the way, I do as you did. I get mentally blocked, by the way. Okay?
Yes,
So,
yes.
يعني don't block, please. Don't block. Okay, this is a case of Langerhans cell histiocytosis. You should ask if this male or female, or you should see, oh, this male patient from the CT. I will ask if this patient is a smoker or not. My differential diagnosis would be Langerhans cell histiocytosis versus others. I think, and you then continue. Okay, you did very well, Dr. Amiga. Um, thank you very much. Who is the following candidate?
Dr. Hania Imran is the next candidate.
45 years old female patient after trauma.
Alright. I'm presented with chest X-ray frontal projection of a patient who presented with trauma. Um, Here I can see that there are multiple chest leads noted.
Excellent.
Um, Endotracheal tube is seen in situ,
Excellent.
and the trachea shows normal, is appears to have normal airway, air
Yes.
outlined by air.
Mm-hmm.
And now I'm looking at the bilateral lung field. I see that there is some volume loss. It is because it's a
No,
traumatic patient and it's not in a very ideal position. So I'm unable to comment on
if I told
the
you
volume.
the
Yes.
patient, the patient is very dysnic, what will you do next?
Okay, if you tell me that patient is this next, so I will do CT scan as it may have any vascular injury such as aortic transection or any bronchial
Three
injury.
hour, 4 hours later, the clinician repeated the X-ray, and this is a new, recently done X-ray of a polytrauma patient. Mhm.
All right. So on this X-ray, there is inhomogeneous opacification on the left hemithorax with some air fluid levels. I can see some air fluid levels in the lower zone, and
Yes.
there is loss of definition of the left hemidiaphragm. So I'm
Yes.
concerned about diaphragmatic rupture, and I will immediately convey my findings to the referring clinician, as this needs further CT scan for confirmation of diaphragmatic rupture.
How could you confirm this is a diaphragmatic rupture?
I can confirm on the ultrasound if available or CT scan depending on the departmental protocol and availability.
The
Because
patient, the patient
yeah,
on the patient is on X-ray table, and you should immediately now, confirming without using any other modalities. What should you do?
Then I could go with the oral contrast examination with the barium swallow. So if the contrast can see outlining the stomach, that it is in the mediastinum in the hemithorax.
Anything more easier than the barium?
Uh, Other than barium, we can use water-soluble low osmolar contrast,
Okay, no problem.
oral contrast.
No problem, no problem, doctor. But you did very well. 45-year-old male patient, shortness of breath, and he did CT in the hospital.
All right. So I'm presented with just extra frontal projection of a healthily mature patient, 45 years old, who presented with shortness of breath.
Yes.
So here, on the first look, I do not see any gross abnormality. So I will now look systematically.
Excellent.
In my routine practice, I will zoom the image to look for any
Yes.
subtle pneumothorax in the apex region. Um, However, the bilateral apical zone appears unremarkable.
Mm-hmm.
Um, yeah, the bilateral lung fields show no area of any consolidation, collapse, or
What
any
will
airway.
what will you do if I told you the patient has persistent complaint for more than 1 month? What will you do next?
Okay, if the patient has complained of for 1 month uh, of dyspnea,
Yes.
uh, yeah, this patient has hyperinflated lungs with more air trapping in the bilateral lung lower zones and flattening of the diaphragm more
What
marked
will
on the
you do
right side.
next?
Next, CT scan would be advised to look for any underlying cystic disease
This is the
or
CT.
lymphatic metastasis. Okay, so I'm presented with CT scan chest axial sections on the lung window.
Mm-hmm.
I can see the bilateral lung fields are hyperinflated. Sorry, are showing lymphatic changes. Okay, first I'll look and then I'll start describing. I can see there is an area of ears. There is an area of um inflammatory. Sorry,